For those of you who have not met me yet, I am Linda Hunter. I am based in Ottawa, and I am here as your host for the day, working with my great partners. And I welcome you all back, everyone, and also those that might have just come on right now. This is our second session, and I really hope you had a nice break, and I really hope people that needed something to eat got something to eat as well. And we have 2 sessions left, but we will be taking a break between them. But I'm thrilled to pass you over to Trudy, who will be the moderator, and her excellent team with Sara, Alex, and Dana, taking us through some really innovative ways at looking at patient engagement and research. So Trudy, take it over, and I will stop speaking and turn my video off as well. Good luck, guys.
Thank you, Linda. So hello, everyone. My name is Trudy Flynn, and I'm a member of the PxP Steering Committee, and I am also an active patient partner, both at the governance level and in research studies. So I will be moderating this section. I would like to acknowledge that I am in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kmaq peoples first signed with the British Crown in 1726. In Nova Scotia, we are all treaty people. So Dawn has put already the links for our bios in the chat, so we don't have to spend time introducing ourselves. Please put any questions you have in the Q&A so I can find them as we move throughout this chat. We will be addressing questions, and as many questions as possible, but we will be doing it throughout the talk versus just at the end. So hello and welcome to session number 2. Taking an alternative path in self-research, a discussion with case studies and examples about responsible self-research and other non-traditional pathways to do research as a patient. Self-research, which means an N of 1, or doing the research on yourself to put together evidence around your symptoms and what you're experiencing. This means looking at credible resources to help you with finding answers on your own, given what you may be experienced with respects to gaps in the medical or healthcare system. So as a person with fibromyalgia and a mother of a daughter who was diagnosed with fibromyalgia at the age of 8, I know a lot about self-research. Fibromyalgia is a condition where you are given the diagnosis and pretty much nothing else. You're left with, so what now? So we've had to do a lot of research and experiment with different treatments on ourselves and find what works the best to keep us both functioning. Interestingly, though, what works for me may not work for my daughter, so it's almost like double the research. So anyway, I am joined today by Dana Lewis, Alex Haagaard, and Sara Riggare, who also know a lot about self-research. I will start with Dana and let her explain her journey with self-research, and then move on to Alex and then Sara. So go ahead, Dana.
Thank you so much. And thank you for everybody for the interest and excitement around self-research. I personally stumbled into self-research focusing on tools and technology related to type 1 diabetes. I was diagnosed with type 1 diabetes at the age of 14. I was given a blood glucose meter that was bigger than today's largest phone, and syringes and a vial of insulin, and basically sent on my way to self-manage my medication every day for the rest of my life. And that's still true today, but the tools and technologies evolved. And about the time I was in college and a young adult when I graduated, I then had access to an insulin pump and an early generation continuous glucose monitor, which were very big advancements for me. But they weren't without their challenges. An insulin pump is designed to give insulin at a pre-programmed rate, regardless of what your blood sugar level is. So if your blood sugar level is low, the pump keeps dosing insulin at the same rate that you programmed weeks, months, or years before. And the continuous glucose monitor has one alarm, one volume, and you can't change it. And my frustration with that alarm volume on the physical device is what led me into self-research and innovation in this whole space. Because as a good patient, I went to the manufacturer and said, hey, you have this device, I'm using it, but it's not working well for me. Can I change the alarm? Can I make it louder? Can I make it different? And I got different responses from different manufacturers, everything from it's loud enough for most people, which Google search results says it's not, because there's tens of thousands of search for louder CGM alarm, and also that they were working on it in the next version. But as many of you know, medical device innovation and iteration cycles are very, very slow. And years later, that feature still hadn't come out. So eventually I had thought, if I could get the data off the physical device and somewhere else, my phone, my computer, I could make my own louder alarm. But I didn't know how to access the data off my device, because at the time you had to press a button and look at the screen to see the data. And you could only get a 30-day download dump of data to a Windows machine. And if you had a Mac, like I did, you weren't able to access your own data. Luckily that changed. Somebody figured out how to get the data off. They shared their code, so I was able to access my data and build a remote monitoring platform that then allowed me to iterate and pair the data from the insulin pump and the continuous glucose monitor. And using that was an absolute game changer, because that enabled me to go from reacting to blood sugar levels to actually building a system to predict into the future, and not just say your blood sugar is already low, but you're going to go low. But if you take action now, you can prevent the low. And so I ended up going on a journey with that evolved into building a full automated insulin delivery system. We decided to share it open source freely so other people with diabetes could use it. And then eventually we started facing criticism and questions from the healthcare community saying, how do you know this works for somebody else? And we said we didn't, but we've shared basically our methods, our process, so other people can evaluate and decide to do it for themselves, going from N of one to N of many. And ultimately I said it would be great if we could do research on it. But because it came from the patient community, some healthcare providers and researchers were concerned about doing research on the community. So eventually I got tired of waiting again and said, okay, we'll do our own research. And we started gathering data from the community and sharing it at conferences and then in academic medical publications. And that made me realize that the barriers to publishing self-research, whether it's N of one or N of many from the community, was actually easier than I thought. You have to learn the process. You have to understand the differences between what traditional researchers do when they're employed at an institution and what the regulations are for that. But that does not mean that N of one or community research can't be published. And I've gone from publishing in diabetes related to this diabetes technology to when I was diagnosed with a new condition early last year called exocrine pancreatic insufficiency. That happens when your pancreas no longer produces enzymes to digest your food, and you have to take pills every time you eat or drink something that has nutrients in it. And at first I was pleased because I said, great, I have this new condition. Doctors understand it. The healthcare system understands it. This is so different than diabetes. This is great. But sadly, I realized that the little research that exists is primarily on the safety and efficacy of the enzyme drugs. There's very little research on what is optimal dose. There are few methods published for how individuals can reach the right dose. And I went, oh no, here I go again, having to research and take my N of one methods of how I found the right dose for me and figure out how do we scale this to the community and how do we work with healthcare providers and researchers to do this more quickly, going both bottom up from the community to researchers, but also how can we more quickly use what I learned in diabetes to then work with researchers and go top down more quickly, because both approaches are valid. Both have flaws and opportunities, but what I'm trying to do now is take both directions at once, move a little more quickly, and benefit from what we learned in diabetes. And so that's some of what I'm excited to share with y'all today and to talk about. There's so many paths to research and self-research. You can join existing projects in the research community, but as a person with lived experience, you can absolutely drive research yourself. And if you can't find the right partners, often we can start with community-based research and go from there, bottom up or top down. So I'm always very happy now in this conversation in the chat, but also in the future, if anybody wants to talk about some of these alternative paths and these different methods, I'm very, very happy and excited to talk about those and help other people in other disease and community spaces really leverage this research. And I did share some research articles talking about barriers to disseminating self-research. I believe those are shared as resources through the PxP program, but I will also drop links in the chat later on so people can directly access these papers. But thank you again for everybody, and I'm very excited to hear from Alex and Sara as well.
Alex, did you want to go ahead?
Sure thing. All right, so I am going to present some slides. Sorry, once I find the right tab, because I'm going to be talking about some sort of pathophysiological pathways that get a little complicated to try and keep track of. So My name is Alex Haagaard. My pronouns are they, them. I'm talking to you from so-called Kingston, Ontario, which is the unceded territory of the Haudenosaunee, Huron-Wendat, and Mississauga people. I also want to acknowledge that land acknowledgements themselves are only a starting point, and I'd like to encourage everyone to consider how to materially decolonize their own research, clinical, and advocacy practices. So I am a design researcher. I am also a patient researcher and advocate, and I consider the self-research and self-treatment that I've done to be my greatest design work. My main diagnoses, or at least the diagnoses that are most relevant to what we're talking about today, are hypermobile Ehlers-Danlos syndrome, mast cell activation syndrome, and postural orthostatic tachycardia syndrome, which are sort of known in the community as the trifecta because they tend to come together very frequently. And I also have narcolepsy with cataplexy, which through my self-research, I discovered is actually secondary to my mast cell activation syndrome. So my journey has been lengthy. I first started having symptoms of the EDS and MCAS around age 4. I remember learning left from right because my left knee was the one that always hurt at the time. And I remember around age 8 telling one of my doctors that it felt like my kneecap was getting stuck in the wrong place. 22 years after that, at age 30, I discovered that was literally what was happening with Ehlers-Danlos syndrome. Your connective tissue doesn't work properly. Specifically, your collagen is messed up. There's the joke. And so your joints, among other things, your joints tend to dislocate and subluxate spontaneously. Hey, girls. No. So, yeah, I wasn't diagnosed till age 30. So that was 24 years of being told that what I was experiencing was just attention seeking. Sorry, I've got to put them in the bedroom because, of course, they've started vacuuming the hallway. Sorry, they hate it when they vacuum the hallway, and of course, they're doing it right now. So I wasn't diagnosed till age 30. That was 26 years of being told that it was all in my head. It was attention seeking. It was drug seeking. I just needed to exercise more, et cetera, et cetera. And then even after I was diagnosed, like Dana described, I was not really offered anything. When I was diagnosed with the EDS, I was offered one appointment with their physiotherapist and one appointment to get orthotics in my shoes. Now, I was bedbound at the time. I was at an appointment the other day, and the doctor I was talking with said, well, maybe that was a good thing because it means that your condition wasn't very severe. And I was like, no, I was literally bedbound at the time. I couldn't work. I was in my parents' basement in rural Ontario and thinking about ending my life. It was pretty bad. But nonetheless, that did not prompt anyone to give me any care at all. Similarly, my narcolepsy was diagnosed faster, but I was still not able to access effective treatment. And once we sort of ran through the first and second line treatments, the sleep specialist I was seeing at the time told me that, well, in the old days, people with narcolepsy just didn't work. So maybe you need to accept that your body just needs to sleep that much. Now, at the time, I was sleeping upwards of 16 hours a day, and every hour that I spent awake, for a person without narcolepsy, it felt roughly equivalent to someone without narcolepsy spending 96 plus hours without sleep. So at that point, you begin to experience psychosis, you begin to become detached from reality, you experience hallucinations, you experience micro sleeps. I would fall asleep, standing at a crosswalk or sitting on the toilet. It was literally torture. It's literally a thing that used to torture people. And yet the healthcare system really didn't exhibit any interest in supporting me. So my quality of life was so bad that I realized I basically had two options. I had to try and find a way to treat myself or to accept that I was going to die soon. So basically, I found a way to treat my narcolepsy, but I'm actually going to talk about the way that I treated my pain a few years later. Among many other symptoms that I've been dealing with, I've had widespread muscle pain for 20 plus years, which was severely exacerbated even by mild exertion. So I was reading about myofascial release after hearing that it's helpful for other people with hypermobile EDS. One of the things that people with hypermobile EDS deal with is very tight muscles, because our muscles end up doing the work of trying to hold our bones together, because of course our connective tissue is not working properly. And then I went down a rabbit hole. Rabbit holes have been sort of a crucial part of my self-research process, is just sort of following the hypertext pathways and seeing where I end up. And I started reading about myofascial trigger points and found that myofascial trigger points contain elevated levels of acetylcholine. And so that sort of flagged something for me. I wondered if I could be experiencing chronic low-level cholinergic toxicity. And we usually talk about acetylcholine in terms of low acetylcholine being the problem. It is a scary thing. Things that are anticholinergic are sort of treated with kid gloves, because they're thought to relate to they're thought to sort of predispose to developing dementia, for example. Now, mind you, the research that actually exists associating anticholinergics with dementia it actually doesn't show a clear association with that, and the conditions under which they studied it involve enough confounding factors that I don't think there's strong evidence for it. But nonetheless, any mention of anticholinergics in a clinical setting will get you told you don't want to be messing with those. You're going to give yourself dementia. However, when I got my diagnosis of mast cell disorder, I also got a diagnosis of cholinergic urticaria, because I had reported that one of the sort of conditions that triggered my anaphylaxis was sort of moderate to intense exercise and also heat. And there's a condition called cholinergic urticaria where you get hives when you exercise or get hot. And it's thought to have two main types: hypohidrotic, where you don't sweat enough or at all. And what happens then is the acetylcholine that gets released, that usually impinges on your sweat glands to get you to sweat, then overflows to the mast cells instead, triggering this hive-like response. And then there's another type, which is where you do sweat, and it's thought to be a hypersensitivity to your own sweat. Now, I wasn't hypohidrotic. In fact, I sweated horrifying amounts. Dysautonomia is great that way. I would wake up with my sheets, like I just throw them in the laundry. It was just horrifying. But I also didn't experience hives. So it didn't seem like it was a reaction to my own sweat. It didn't really make sense. I wasn't getting any dermatological symptoms, really just the anaphylactic stuff. It seemed like there had to be something systemic going on. So I had already been wondering if possibly I was experiencing some kind of cholinergic excess caused by something other than overflow from the sweat glands. And then I started looking up the various symptoms of cholinergic toxicity sort of before you hit the full-on cholinergic crisis that will kill you, the sort of lower level stuff. And I experienced a great many of them. And the thing that was really, really interesting to me was that increased levels of acetylcholine are found to be associated with narcolepsy, with cataplexy, at least in dog and mouse models. Oops, no. So both my narcolepsy and my apparently cholinergic anaphylaxis were resolved by treatment targeted to my mast cell disorder, which included antihistamines that also have substantial anticholinergic, specifically antimuscarinic action, which is to say Benadryl or diphenhydramine. So I wanted to find out if there were any plant or over-the-counter medicines with anti-nicotinic action that I could try and use to address the muscle pain. Now, this is anti-muscarinic and nicotinic are the two main types of acetylcholine receptors. And it's easier to find anti-muscarinic ones. Anti-nicotinic ones, most of the stuff that's out there will kill you very quickly if you get the dose wrong. It's curare. It's like, you know, what we know as blow dart toxin and what they use to paralyze you during general anesthesia. But bupropion, Wellbutrin, is available by prescription for depression and for smoking cessation. Interesting. It has anti-nicotinic functionality. I had actually tried it before early on in my narcolepsy journey, but was taken off of it because I had tachycardia, which is a thing it can cause. And of course, at that point, they hadn't diagnosed the POTS yet. So I asked to try it again for depression. And a couple weeks after starting bupropion, I found that I was able to walk a kilometer without pain, when before I could walk 50 to 100 meters at best without my back seizing up. Over the next few months, I stopped using my wheelchair. I began walking 3 to 5 kilometers a day, and I grew 2 inches when my lifelong bad posture resolved itself. So that was sort of the pathway, one instance of how I've used this particular pathway, where it sort of is operating differently, because obviously as a patient, I don't have access to tests, to test results. So I have to operate a little bit differently. I go directly from symptoms, try to figure out a mechanism, and then essentially try to identify treatments that I can try reasonably safely, and then through that do hypothesis testing of my mechanism. And I think I'm probably over time, so I will end it there.
Thank you. Thank you, Alex. And I'll turn it over to Sara.
Thanks, Dana and Alex. Really, really fascinating to hear your stories. Even though I've heard Dana many times before, it's always, there's always something new there. My name is Sara Riggare, and I live in Stockholm, Sweden. And I live with Parkinson's disease, which is a neurological condition, which is generally said to be one of the most individual conditions there are. I'm not sure if anyone wants to sort of protest that, but that's what I've heard. And with that, it means that there are a very large number of symptoms, both motor symptoms and non-motor symptoms, that you can get. And that the treatment, the combination of symptoms and the treatment you get for it is very individualized. So I had my symptoms unusually early. I started experiencing my first symptoms in my early teens, around 1984. I was correctly diagnosed 18 years later, when I was 32. But in the meantime, I had trained as an engineer, and around 2010, I decided I wanted to combine my patient experiences with my engineering training and try and improve things for myself and others with chronic diseases. So I went back to university and started studying at the medical university, Karolinska Institute here in Stockholm, with the aim of being a babelfish. I'm not sure how many of you are Hitchhiker's Guide to the Galaxy nerds, but a babelfish is a fish you put in your ear that can translate between all languages in the universe. So I wanted to become a babelfish to translate between researcher language and patient language, basically, both ways. And I had realized that to be taken seriously by researchers, you have to be a researcher yourself. So then I figured, okay, I can't do that because I'm not a researcher. But then my husband said to me that, well, maybe you can become a researcher then. And at first I thought, no, of course I can't. I'm only an engineer and a patient. But then I thought, well, maybe I can. And so that's what I set out to do. And I didn't realize at the time that what I was doing was that special for the medical community, because I just applied engineering thinking on my own condition, trying to optimize my own treatment, trying to find the best ways of combining my medications. So for Parkinson's, you take a lot of medications. This is where I keep my pills. I take medications 6 times a day with different time intervals in different combinations, 4 different prescription medications in different combinations. And the timings of these drugs are very, very important for me to function properly. Both because if I get too much medication in my body, I will get side effects. If I get too little, I will not get any effect. So it's a sort of constant battle between rigid and too little motion and too much movement. And so I did apply sort of N1 methods to my own condition, working to develop methods for me to optimize my own treatment, and very surprised that there was not such a thing done before in Parkinson's, and basically still isn't. Because the randomized control trial can only take us that so far. It doesn't tell us what's good, what's the right treatment for me specifically is. So going back then to university was a real. It really changed my mindset. I learned a lot about medicine and learned a lot about also how to navigate the research system, the scientific world. And to cut a long story short, I did defend my PhD thesis about 18 months ago now, in March 2022 in the Netherlands. It took me pretty much exactly 10 years to finish my PhD, but it was the best thing I've done. I learned so much on the way, and it's wonderful to be able to now share my story and share my methods here as well.
Thank you. So we do have a question that, and I think we'll be discussing this in our panel discussion, but how can you be assured that the info you research about your particular disease is credible? Because there's a lot of Dr. Googles out there. Dana, would you like to talk about that?
I'll let Sara start because I know she's going to jump in, and then I'll follow with a comment.
Okay.
Yeah, I mean, Dr. Google is used often as a sort of a bad word, basically from the medical community. But I mean, where would we all be without Dr. Google? We wouldn't be anywhere. So I mean, it's a thing. Of course, you have to learn how to find the right information, and the question as such is it's a difficult one to answer easily with a simple answer. But we have to learn, rather than waiting for medical professions to give us the fish we need to learn how to find the fish ourselves.
Yes, I think learning how to fish is hard. I think something I put in the comment in the chat earlier in the conversation was talking about looking directly at the medical research literature. Things like Google Scholar are a good starting place rather than Google as a generic web engine, because then you're looking specifically at the literature. I'm going to share my screen though, because I want to contextualize something about when we look at medical literature. With a recent experience I had looking at EPI, I started looking at all these papers to try to understand, when does this condition happen? Who is it happening amongst? And I quickly found literature that said over and over and over again, the common theme is that EPI is prevalent in pancreatitis, cystic fibrosis, and pancreatic cancer. And the reason that people say it's so prevalent is because up to 80 or 90% of these populations potentially have EPI. And so that's why in the literature, all of the clinicians are saying and the researchers are saying that it's most prevalent in these conditions. And it's just accepted. Like, this is the thing that's said in the literature. But I had gone to say, well, how common is pancreatitis? And how common is cystic fibrosis? Because I didn't have a kind of a framework for the scale of these numbers. Well, in the large general population, this is a tiny fraction of people. The prevalence number on these conditions are like 0.04%. And when you compare it to the overall population of people with EPI, you can see that these conditions, even if 100% of them had EPI, this is a small fraction of the overall population of people with EPI. And that means the bulk of people with EPI are completely missing from the literature in terms of understanding their prevalence, their diagnosis, whether their symptoms and treatments are different or the same. And this was really incredibly frustrating to me, because what this says is the literature is not always perfect. The literature is not always right. And I wanted to bring this up because if you start researching and you're like, I have an experience that is not represented in the literature, that does not mean that you are wrong. That does not mean that your lived expertise is invalidated. It could just mean that there is an error that's propagating through the literature like a game of telephone, like these prevalence numbers. It's just kind of like a game of telephone. Like the same thing keeps getting repeated until somebody brings it up and kind of checks those numbers and says, maybe this isn't right anymore. Maybe we know more. Maybe we know different. And so a lot of times this idea of self-research is incredibly powerful, and it's worth publishing. It's worth talking about. It's worth sharing our case studies, including in the medical literature, because that can then change all the literature going forward. And it can set the stage for grants and research projects to actually then address the thing that's not in the literature. So sometimes it can be super, super unmotivating. I absolutely get that. But I also look at it oftentimes after I get over the frustration as an opportunity of like, okay, here's something we can do to try to change this. So kind of a lot to say about that, but there's both ups and downs to finding something that's repeated over and over again on the internet. But the things we watch out for in terms of credible information on the general internet is also, we should have that same lens when we look at the medical literature, because some of these things do propagate. And we also potentially have a responsibility to help update the scientific literature, because we are the experts, right? We have this lived experience. We see things that the clinical care system doesn't see. And so again, super frustrating, but a lot of opportunities to change things.
So, and I would like to add in there that you don't have to be educated in research, because when I started out looking for research, research. I do have a nursing background. I do not have a research background. So I found research, I use PubMed and I use Google Scholar, but I find it difficult to read. So I had to go back to the very basics and teach myself how to read a research paper. And I'm glad that was, Amy, that you put that into the chat, because I had to do that. I had to learn how to read beyond the headlines, because the headlines are not always correct. So in the fibromyalgia community, everyone on Facebook and we're sharing this study about how fibromyalgia has been determined to be an autoimmune disease. And when I read that research, it was 5 mice they had tested. That's it. And so, yes, the mice, it reacted that way, but that does not mean the people were going to react that way. And everybody in the community was, oh my goodness, they found what we are now. We're an autoimmune disease. When in fact, no, they found 5 mice that had an autoimmune disease. So you really have to learn to read beyond the headlines. So Alex, do you have anything to add to that?
Yeah, I think just echoing what everyone else has said, and I would say sort of, I think we tend to zero in on the headlines and maybe the abstracts. And for me, the methods section is always the part that you want to zero in on and look at exactly like how many individuals have they studied, what individuals were they studying, but also examining like how have they analyzed this and how have they accounted for the fact that this may not be representative of everyone? Because this is the other thing too. A statistical analysis of something predicts what most of the people in the population are going to experience. It's not predictive of what an individual outcome is going to be like. And I think Dana talked about, no, sorry, Trudy, you were the one who talked about this too, that what works for you does not necessarily work for your daughter. And that's the thing, even though we may have the same condition, you know, our genetics, our biomolecular makeup is different. And so what works for, you know, the group as a whole is not necessarily going to work for the individual. And so I think like, as much as learning to read scientific papers is useful, I think also just developing critical reading and critical analytical skills in general is really important. And like, for me, reading critical theory has been really important. Like I always feel pompous recommending it, but like Michel Foucault, who has written Critical History of the Clinic, you know, that has been really useful for me to understand the ways that, you know, the clinical gaze is fallible. It's not all knowing, and it has its own biases embedded into the way that they work, and then being able to apply that to how I read scientific papers.
Yeah, and I just dropped
may I jump in? Sorry, Dana. So I just want to add to what Alex said there about, and we've all said it now, that what works for the general public or the average patient doesn't necessarily work for me or for your daughter, Trudy, for that matter. I just want to add that kind of distinction can also be called personal science, and that's also what my thesis was called, personal science in Parkinson's disease. And for those who want to read more about that, I'll add the link in the chat later. And then I also know that it's also mentioned in a edX course, open course from Stanford University. I'm wondering if Amy maybe can add a link to that in the chat as well.
And I was just going to chime in with a comment. I think there's some questions saying, well, you know, how can we do this if we don't have experience, or maybe people are feeling intimidated by this? And I think one really, really useful tool at an individual level is the large language model tools that are now freely available. I'd recommend not asking it directly, what do you know about diabetes, EPI, fibromyalgia, because this isn't a thinking being that can live look up on the internet and tell you information that is factually true. But what these tools are really good for is essentially doing concrete tasks that you give it with information. So for example, talking about the methods paper, if there's a methods section and there's something in there you don't understand, copying and pasting that paragraph into an LLM and saying, here's a methods paper, I'm having trouble understanding it, please rewrite this in lay language or plain language, and having it write it for you. And if you need to, take a single sentence and have it rewrite it for you and ask questions about it. Maybe they use a word like heterogeneous or some other word that you don't understand. And you can ask it questions about, what does it mean in this context? Is this how it's typically used? You know, how might somebody use it in this example. And you can kind of have a conversation with it the way you would talk to the researcher themselves if you were talking to them live, and ask questions about that. I've actually used that a lot. Sometimes when I submit papers and I'm the lead author, I get peer review comments from researchers, and they use language that I kind of recognize, but I don't fully understand. And I'm afraid I might miss the context. So I often paste the paper and I paste the comment in and say, perhaps, what does the researcher mean by this? Like, how is this word used? What do they mean? How might I respond it? I put my response back in and say, does my response address this comment in the context of this paper? And so tools like that can be really, really useful for helping us translate and check our understanding. And then you don't have to worry about, is this a dumb question or I don't understand, because it's an LLM. They don't care. They're not judging. There's no shame. And recognize that all of us do it too. We're always looking up these tools, these words, because not all of us, most of us, other than Sara, aren't trained or didn't seek professional training in this. We're learning as we go. So we might look confident and hopefully not intimidating, but I'm trying to encourage people of start with something, anything. And every word that you look up, every sentence that you paste in, every paper that you read is going to help you learn and evolve your understanding. And then you'll be able to turn around and help somebody else, which is honestly the best part of doing self-research, is then being able to share what you know and what you've learned with other people.
So there is another question in the chat, which is actually was going to be part of our conversation. And that is, how do your healthcare providers respond to your self-research? What have you learned about the best way to introduce your research to them? So Alex, do you want to start with that?
Sure. Yeah, they don't respond positively. I had one doctor fire me when I told him that I'd sort of succeeded in self-treating my narcolepsy this way. He told me to come back when it stopped working for me. So far it hasn't. It's helped me more than he ever did. So, there's that. I will say that I've sort of, so my situation, I think, is different than some folks, because for me, I've never gotten any care that has helped me from doctors. So I can afford to be a little antagonistic with them. And I find I use that. I use many of my appointments just as opportunities to advocate, because I have very little faith that they are going to do anything to help me. And I also find that it sort of works very well as a benchmark, because if the doctor is not receptive to my self-treatment practices, my self-research practices, I can pretty much guarantee that it's going to be a wash, the interaction. Whereas the rare occasions where they have been accepting of it, those have been much more positive relationships. So it works for me very well as a metric. And yeah, I've given up on receiving support from the clinical system largely. So when I go see doctors, I sort of view it as a gamble on whether it's actually going to get me anything that I need, or whether it's just an opportunity to advocate and hope that the next time they see someone like me, they do a little bit better.
Okay, so
Can I add an alternative perspective?
I was going to say, Dana, would you like to? Because I know you have a different experience.
Yeah, Alex and I have talked about this before. So I'm based in the US, and I require a prescription for insulin to keep me alive. Without insulin, I die. And every year through insurance, I'm required to go to the doctor, get fresh chart notes, get a fresh prescription, and prove over and over again I still have type 1 diabetes, haven't been cured, still need a prescription. And I honestly can't afford to antagonize my care providers, because it is more closely linked to life and death. And for many people in the US, depending on where they live, finding a different healthcare provider is often not an option. So I often am very strategic about when and how I bring up my self-research. With my current diabetes doctor, I'm fortunate that I did not scare him off with my self-research. He didn't understand it, and he kind of ignored it for the first couple of years when I did it, especially my innovation work. But he eventually realized that I am somebody who does self-research for the benefits of understanding my care plan and my situation, and he's eventually embraced it. I was surprised at my last appointment where I had asked him a question about a new thing that I had, and we were kind of looking at my lab results and trying to figure out what to do. I asked him a question of whether, this symptom is typically linked to this condition, or does it suggest something else? And he started to respond and then stopped and said, you're the kind of patient who would bring up a case report you read from 1979 about a patient with this cluster of symptoms. So I should ask you first, have you seen anything that suggests that this symptom correlates with this condition? And I laughed. because that showed me that he really understands that I do self-research and that it's important to me and it's beneficial to both of us. And I said, no, I haven't. And that's why I'm asking you. So based on your clinical expertise of treating thousands of other people, have you seen this cluster? And he said, no. And so mutually we agreed, okay, this probably doesn't match. This means there's something else going on. We'll investigate it and move on. But honestly, it took almost 10 years to reach that point where he would make that comment and understand it. And I would, feel really comfortable with talking about self-research with that doctor in that way. So I recognize that it can be really, really hard. And sometimes being strategic about how you frame the research. I don't go in and say, I read about this on the internet. As we start talking and the doctor sharing their expertise or their plan, I start asking questions to see if what they're suggesting and the way they're framing things matches what I've read in the literature. And if it matches, that gives me a sense of confidence. And sometimes I validate what they say with, oh yes, I've read, X and Y pieces of literature that suggest that. And other times I go, this doesn't seem to match. Have you read X and Y and Z? And you have to recognize that doctors are tasked with a lot. So even if they're treating a kind of known condition, there's so much research out there, and staying on top of everything is really, really hard. And again, we're the experts on our situation. So sometimes they don't always know the latest, or they're not always, understanding of how that contextualizes to our individual experiences. So I just wanted to frame, I think it's different for everybody depending on their conditions, their relationships with a healthcare provider, the insurance situation, where they live, what kind of care you're seeking, and it can be really stressful and hard, and I get that. But I just want to share that with my healthcare provider. Been lucky enough to have a relationship where I would say the first 2, 3, 5 years, I wasn't so confident about it, but now the last 5 to 10 years has shown me that, I really can bring all of my self-research and have a good collaborative relationship. But in some cases, it takes time.
Thank you. So Sara, I have a question I'd like to ask you. All of the panel are so inspirational. How did they reassure all of us who are in awe of you that more of us have the capability to do this? So do you want to answer that, Sara?
Yeah, sure. Because 10 years ago, I wasn't this capable or knowledgeable at all. I mean, knowledge is not a constant, and I can understand that you see us as awesome and unattainable, but we've been the way you are as well. It's just a matter of starting to sort of find a thread to start winding, and then you'll end up in lots of rabbit holes, but you'll also learn something on the way. So remember, with the right support, we can all do more.
Thank you.
And if I may, I will also want to touch on something that was in the chat and not in the Q&A. How researchers have reacted to our work, and Dana and Alex has talked about healthcare professionals. I've met that as well, but I want to mention something, because researchers sometimes see us what we do as threatening in some ways, a bit strange, but they do, and that sort of the peak in my experiences there in a negative way was when I was talking to a professor at Karolinska Institute, and they said, but Sara, why would patients want to do research on themselves anyway? Isn't it better that you give your data to a proper scientist? And I honestly didn't know how to respond. I didn't know if they were joking or not. But so there is a lot of resistance within the scientific community as well. But find the ones that you can work with and liaise with them would be my advice.
Thank you. So sometimes people do self-research trying to find a diagnosis because they can't get diagnosed. And that's very common in the fibromyalgia community. They usually can diagnose themselves long before they can get a doctor to diagnose them. But self-research is not just about diagnosis. So Dana, sometimes self-research is knowing your records well. Can you elaborate on that?
Yeah, I think a lot of times we are often treated as patients based on general guidelines or general best practice related to data. And a lot of times what's normal for us in our body may or may not match with kind of the defined normal range of things, right? So imagine you had a thyroid test and the normal range on the value is between, X and Y. Well, you might be close to X, the bottom end of the range, And a clinician might look at that and say, oh, you're within range, there's nothing to be concerned here. But if you've looked at your records in the past, you can say, well, actually, there's this trend, I'm drifting down, you know, and I have these symptoms. So even though technically this is normal, you know, this number is out of the normal for me. So a lot of times my self-research at an N of 1 level has been really deeply understanding what have my symptoms been, but also what have my lab records been, looking at how they're trending overall in context of the normal. And many of you who've looked at your medical records online have probably also seen this. If you go back, for example, for those who have my chart and you click on a lab result, a lot of them now have like view trends, and you can see over time, and there's lines for like the bottom and the top of the range, and it shows your numbers and how they change over time. Well, sometimes the bottom of the range numbers are different because over time, the guidelines or best practices that a healthcare system used for what is the bottom end of the range could differ. And so sometimes you might be within range now, but that number would have been out of range for what was used, you know, 5, 10, whatever years ago. And so looking at that can be helpful for saying like, yes, it looks like I'm in range. However, you know, I am trending lower, or this is lower for me. And in context with these other labs or my symptoms, you know, this is a clue that there's something going on, and I want to talk about it, investigate it, do something differently. So I think that can be really helpful, you know, like just knowing your information and knowing your situation really well. And I get that it can be hard. You know, for a lot of us, we have multiple conditions, multiple symptoms that come and go, life stresses, you know, all of this piles in, and it's absolutely hard sometimes. But the more data that we have on paper or digitally, where we can look over time and show how things have changed or not, we can start to see correlations. Maybe not causation, maybe not understand, okay, this is causing this, but we could say, this is more evidence that there appears to be something going on. I would like to do something about it. Because clinicians otherwise might be like, well, you're kind of in range, I want to wait and see. But oftentimes it's important for us as patients to then say, no, it's time to do something. Like, I was okay waiting for the last 6 months, 2 years, whatever, but because of these symptoms, because of the impact to my quality of life, you know, let's take the next step. What are those? And coming up with a plan. So kind of having that big picture insight and developing opinions, you know, based on your data of, you know, I'm willing to sit and wait and see, or, you know, I'm ready to take some action. Let's figure out what that action looks like. That can be a really valuable thing to bring to the conversation.
Alex, did you want to elaborate on that?
Yeah, I just want to share a practical tip specifically for folks living in Canada, because here we do not have as comprehensive electronic medical records as they do in other places, which is useful in some ways in that psychiatric diagnoses and things like that can't follow you as easily as they can in the States, for example. But it can also be troubling in that you don't have access to your data in a way that allows you to advocate like this as easily. So a thing that I have recently discovered is that it's a lot easier to get a hold of your data if you get your blood work done at independent labs versus at the hospital lab. Because with the hospital, you have to go through the records department, you have to fill out a form, you have to often go down in person, you have to pay a fee, which for any of us who deal with energy limiting conditions and executive dysfunction is a nightmare and often like flatly inaccessible. Whereas increasingly the independent labs now have online portals where you can just access your data for free. And that's a thing that has sort of happened more and more over the last 5 years. So strategically, you can take your requisition anywhere you want to go. And if you take it to the independent lab, you're more likely to have access to your data. And then, yes, you can do exactly what Dan is describing, which I literally did a couple months ago. I'm dealing with some new inflammatory joint pain. And they were trying to tell me first that, you know, my erythrocyte sedimentation rate and my C-reactive protein were only slightly out of range. And I said, well, no, I need you to go back. And they said, that's to be expected given your mast cell disorder. And I said, well, no, I'd like you to go back and look at the previous tests, because actually I know that they have never been out of range, because that was one of the reasons that they didn't want to diagnose me with mast cell disorder in the first place. And sure enough, they looked back, and yes, my levels were only slightly out of range, but they were about 5-fold increase from what they usually are. And indeed, despite my mast cell disorder, they have never been out of range. They've always been well at the low end of normal. So that convinced them to give me the rheumatology referral that I needed. So yeah.
Thank
little
you.
bit of practical strategy.
So a couple more things I want to cover, and we have about 11 minutes left. So one is responsibility, you know, how you need to do self-research responsibly, and some risk involved with that. So Sarah, do you want to talk about that? Start that off?
Yeah, sure. The responsible part is very, very important, and we have a responsibility both, of course, to ourselves, but also to our community, our fellow patients, and as well as the larger community. And even though, as soon as something is made public, it doesn't have to be in a scientific article. It can be in a blog post. It can be in a podcast. It can be in a post on social media, on Facebook or X or whatever. We have a responsibility towards other people towards being honest with what we're doing and also the risks involved. Because many will look to people who are doing this and think, well, if they're doing it, I can do it as well, and without thinking maybe about their personal individual risks and the consequences of that. So we all have to think very carefully before we make anything public in any sort, shape, or form.
Thank you. Alex, did you want to discuss that?
Yeah, so I would say when I share my sort of self-research results, I am always very careful to frame it as I'm not recommending this as something you do. I'm sharing what I have done, the ways that I found this information. I share it more as sort of an account of how I did that research, more so than here's the specific thing I'm telling you to do. And I also try to be very careful about sharing the risks that I am aware of too, with the anticholinergic stuff. I can't say for certain that it's not associated with dementia. It may be associated with dementia for people like me. It may be associated with people with dementia who do not have the same biochemical makeup as me. Like, there are undeniable risks. And I also sort of share my risk assessment process that I use when doing these things. Like, for me, the risk that I might develop dementia in 20 years from taking anticholinergics was worth the fact that I might be able to have a tolerable quality of life now, because if I didn't take these, I was going to die in like a year or two. So like, for me, that was an easy decision to make, but for someone else, that, risk benefit equation might be very different. But I think being really, really transparent about all of that is a crucial part of this kind of work.
Thank you. And someone asked a question about getting raw data and, for example, blood work. I have to say that I should have known this a long time ago as a nurse, but I used to take it for granted when my doctor would say, well, everything's normal. And I've learned the hard way that when I would then be told, oh, this has been elevated for 2 years, why didn't we look at this? When I leave a doctor's office now, I ask for a copy of my blood work and I take it home and I create my own chart and keep at home. So even though I don't have electronic access, I make sure I either get it emailed to me or I get a printed copy before I leave the office. So is there anything else?
Another aspect as well. I've been thinking about this for a while. And so both Dana and Alex talk about blood works and measures and sort of different kinds of objective measures. With Parkinson's, we have nothing. So Dana will know this. I sometimes use the expression that I have diabetes envy. And of course, I understand that is sort of not something you say lightly. But compared to Dana, that has both a value to aim for with day-to-day management, as well as a long-term prognostic value in HbA1c, we have nothing in Parkinson's. So, and I'm not saying that's it makes it harder to navigate. Let's just say we don't have a diagnostic marker for even for a test for saying we have Parkinson's or not. We don't have any blood works to be followed or anything. So it makes it even more challenging to work like this. But it's not impossible. It makes it harder, but not impossible.
So I have the same issue, Sarah, with fibromyalgia. There's no marker or a lot of my blood work is always normal, but I find having fibromyalgia, a lot of my symptoms get dismissed and it's probably just your fibromyalgia. So I like to keep
Oh,
track
yeah.
of the other blood work that comes in and make sure my cardiac enzymes are fine, my liver enzymes are fine, because I don't believe everything I feel is just fibromyalgia. So,
Yeah, I think
Sarah,
sorry, I was going to say, I think it's super common for a lot of us with multiple conditions for one to kind of be the one that doctors know and attribute all symptoms. Diabetes, here's the opposite of envy. Like, yes, in some cases we have a lot of data, but all of my care, everything is attributed to diabetes. And sometimes I'm undertreated and not given the correct care because they're concerned it'll affect my blood sugars. Sometimes I'm overtreated to my detriment because they're concerned about diabetes. So that can be an issue. I will say I have a similar experience to Sara and the Parkinson's perspective with EPI. There is a diagnostic test that's not widely accepted. So there's no universal clear, here's how you get diagnosed. And for the treatment, there is no metric, blood work, marker, anything that is used for treatment efficacy. And there's 0 studies looking at proper titration dosing, like I said. So I've actually had to create a measure for evaluating the amount of dose that I'm taking compared to what I'm eating. So I've developed a ratio for that. And I ended up creating an app for other people to use to more easily do that. Shared openly for free so other people could do it. But then I also realized that people still, even with that tool, don't have a way to systematically really understand and categorize their symptoms and have they improved over time. So I actually ended up developing a symptom survey specific to EPI and tested it in people with and without EPI. And I'm working now on partnering with traditional researchers to validate this in the literature so it can be used potentially as a predictor for diagnosis. It might be as good or better as the vague diagnostic tests that nobody believes in, but also then to look at treatment efficacy and helping individuals and clinicians understand, are things improving? Because when a patient presents with GI symptoms, most doctors are like, whatever, it doesn't matter. Well, for some people with EPI, they're having diarrhea 14 times a day and they're afraid to leave the house. Like, that is a huge quality of life thing. And, we can numerically understand the severity of a symptom and the frequency, and understand if you go from 14 rounds of diarrhea to 2, that is an improvement heading in the right direction, or preferably go to 0 and improve other symptoms as well. But this is really where, kind of our interest as the people with the liver condition is driving a lot of this work. And we have to, because we understand the urgency of living with these conditions. And as individuals, it can feel overwhelming and tiring to have to keep pushing. But the work that we are doing as self-researchers sometimes feels like nobody is listening. But if you come up with a good method for you, whether it's for diagnosis, whether it's for treatment monitoring, whether it's for any of these things that we've talked about, oftentimes it will help not just one, but hundreds of other people. It doesn't have to work for everybody with the condition, right? We've talked about how everybody is different, even with the same family and the same condition. But there's probably hundreds or thousands of other people who could benefit from either what you're doing specifically or understanding the process at which you arrived at what you're doing. And that's what's so valuable, I think, about all of us sharing what we're doing, because it does allow us to go from the N of one to the N of many of trying something, when the something is probably for a lot of us better than nothing.
thank you. That's great. So one last thing, and we only have about 2 minutes to answer this, is it's not okay when we do this as patient partners, but it is okay when academics do self-research. Sara?
Yeah, there's been a number of Nobel Prizes handed out to academics doing what is called auto research or auto experimentation or self-experimentation. So I think the world is changing, and we need to change with it.
Do you have, just one last question, actually, do you have problems when you try to publish your self-research with the ethics boards?
Yes, I
Uh-oh.
put a link in the chat previously. I can repeat it.
Okay, thank you. So this is very good. We have 2 minutes left. Anyone have anything else they'd like to add?
I'll just add the question of ethics research has come up. As somebody who does not work at an institution, I am very much outside the system. So I have a lot of practical experience doing N of one and community-based research and getting it published in the journals. So I think there are a couple people who had comments, and I know we're out of time, but I'm very happy to chat and talk through individual situations and kind of share some of the things that have worked for us. I have published without ethics because I'm not at an institution. That doesn't mean the research isn't ethical, but what I often do is show the work of what the ethics process is that normally would be submitted to an IRB or an institution. And the journals so far, the editors, the peer reviewers have all been satisfied with that because we're actually demonstrating here's what the ethics are, the consent process, et cetera, et cetera. So sometimes you just kind of have to explain it to journals, but usually that's not a complete barrier from getting the research published. But like I said, very happy to keep chatting about that offline as well.
Okay, that's very interesting. Dana, I didn't realize you could do that. So that would be great information if you have any to put in the chat, or if you want to chat later. So, well, thank you, everyone. This was really interesting. I want to thank the panelists, Dana, Alex, and Sara. This was really great. And so we will wrap up this session, and we will have a 30-minute break now, and we will return at the top of the hour. Thank you, everyone.